you can remember the things better, so I'll just go for that. So there is an algorithm which is given here. This is usually found in all the books in American Heart Association algorithm for adult immediate post-cardiac arrest care. So once the patient has got the return of spontaneous circulation, your duty is to further ventilate and oxygenate the patient so that you can maintain oxygen saturation to more than 94%. This is the first and foremost thing that you have to. So make sure that either the patient breathes spontaneously and you can give supplemental oxygen, or if he's got very weak attempts or his respiratory attempts are not sufficient, but he has a palpable pulse and a stable BP, if you allow him to hypoventilate, again he will go for an arrest. So make sure that ventilation and oxygenation are maintained, which is the primary concern. So consider advanced airway and waveform capnography for assessing that. But at the same time, do not hyperventilate, because these patients, if you wash out the carbon dioxide by hyperventilation, you will cause again a respiratory arrest, or they will cease to breathe. So maintain normocapnia by proper assessment of PTCO2 levels. Then treat hypotension. Sometimes, patient must have, you may be able to feel a pulse, but the blood pressure may be quite low. So in that situation, you must try to maintain adequate pressure so that organ perfusion will take place. And so systolic blood pressure should be, if it is less than 90, these are all the following measures that you can try: is IV or intra bolus of IV fluids, vasopressor infusion. Treatable causes has to be taken care of, which are reversible causes given here, like hypovolemia, hypoxemia, acidosis, hyper or hyperkalemia. All these things have to be corrected. And you must take a 12-lead ECG, because cardiac arrest can result in a myocardial ischemia also. And so we have to take an ECG to find out whether the patient has any coronary ischemia or infarction that has been caused by the cardiac arrest. Then to assess the cerebral conscious level or sensorium, see whether the patient follows commands. If he is able to follow the commands, rule out any coronary ischemia or coronary infarction, and then try to do the advanced critical care for that by coronary reperfusion. If he is not conscious, if he is not following commands, consider protecting the brain by considerable induced hypothermia. So these are all the 8 steps that are being given. One is you establish that there is a return of spontaneous circulation. Once you are confident that the pulse is returned and patient's heartbeat is well heard by auscultation, optimize ventilation and oxygenation, and maintain hemodynamic stability by stabilizing the blood pressure with IV fluids and vasopressor, and treat any underlying causes which cause the cardiac arrest, and then take a 12-lead ECG, assess the conscious level. If the patient is not responding or drowsy, go for hypothermia, targeted temperature monitoring with hypothermia to prevent further ischemic damage to the brain or hypoxic damage. And then if the ECG shows any evidence of ST elevation MI, then try to re-establish the coronary perfusion by intervention. But if the coronaries are normal and there is no ischemia, then go for advanced critical care support to maintain and sustain this returned spontaneous circulation. So if you remember this algorithm itself, that will be enough. But if you have time and if you want to write more on that, then you can write by multiple system approach to cardiac arrest. One is the ventilation. Again, what's given more in detail. Capnography, what is the reason for that? And if the endotracheal in position, maintain ETCO2 between 35 to 40 and PaO2 more than 40 to 45 millimeter. I mean, PaCO2, the 40 to 45 millimeter. Take a chest X-ray to confirm secure airway and detect cause or complications like pneumonitis, pneumonia, or pulmonary edema. Then pulse oximetry ABG to maintain adequate oxygenation. The PaO2 try to reach as much as possible. Gradually reduce FiO2 as tolerated and maintain a PaO2-iO2 ratio for acute lung injury. And mechanical ventilation, if it is needed, uh, tidal volume of 6 to 8 ml, that is what we saw as a protective ventilation, and titrate minute ventilation to achieve a end tidal of carbon dioxide level of 35 to 40, and reduce FiO2 gradually over a period of time. Hemodynamic, frequent blood pressure monitoring, or you can put in an arterial line once pulse become palpable. You can put in an arterial line in a patient with comorbidity who have been revived, and maintain perfusion to prevent recurrent hypotension. And the MAP should be more than 65, and systolic BP should be more than 90. And the methods of treating hypotension are by the fluid bolus as tolerated, dopamine or epinephrine and epinephrine. These are all the drugs that you can use. For cardiovascular stability, continuous cardiac monitoring. For the rationale for that is to detect any arrhythmias, which if they have been the cause for cardiac arrest, we must see whether they are returning, and no prophylactic antiarrhythmic should be given. If there is no arrhythmia, no drugs to be given, only treated according to whatever the arrhythmia is acquired, and remove reversible causes. 12 VCG, troponin levels can be assessed to rule out ischemia, coronary ischemia also, and assess QT interval, and put coronary syndrome with aspirin heparin transferred to coronary care unit. And echocardiogram can be done to assess the global stunning or wall motion abnormalities, structural problems, or cardiomyopathy. And treat myocardial stunning with optimized fluid requirement, dobutamine, and mechanical augmented support like IABP and other things. Neurological, check the pupillary light reflex and corneal reflex, spontaneous eye movement, gag, cough, and spontaneous breath. EEG monitoring if the patient is comatose. Anticonvulsants if the patient has seizures. Sometimes, after recovery, they may have hypoxic encephalopathy induced seizures may be there. So that also to be corrected. Core temperature measurement is done, and prevent hyperpyrexia also. At the same time, induce therapeutic hypothermia if there is no contraindication by cold IV fluids or surface or endovascular cooling. And after 24 hours, slowly rewarm the patient. So the targeted temperature monitoring and management should be only for maximum 24 hours. After that, you should start rewarming the patient. Consider non-enhanced CT if it is required for any intracranial process. Sedation and muscle relaxation to prevent shivering, agitation, or ventilator disturbance. And coming to the metabolic, serial lactate estimations, then the serum levels of various electrolytes, especially potassium, urine output, serum creatinine, maintain euvolemia, serum glucose, avoid hyperglycemia or hypoglycemia, treat hypoglycemia with dextrose, treat hyperglycemia with short-acting insulin, and avoid hypotonic fluids, especially which may increase cerebral edema. So these are all the system-wise follow, which also can be written, or you can follow but the algorithm does not give the detailed follow therapy. So I think this will be a better way of writing the care, like starting from the ventilation, hemodynamic status, cardiovascular status, neurological, and metabolic. So these 5 components, if you maintain, I think that will be the better way of answering this question.